Yeah. Good evening, everyone. I first of all would like to thank Ms. Priyanka for inviting me. I think she's doing a tremendous job in getting us all together and making us speak to people who are interested in knowing sarcomas. Uh, well, we wouldn't call ourselves sarcoma experts because we are still learning about sarcoma, and it's a challenge really compared to other tumor sites that obviously because they are rare, we need to individualize the treatments, and yet we need to follow certain basic philosophies of evidence-based medicine, and it is extremely challenging. And last week we learned something about sarcomas in the abdomen, in the retroperitoneum, whether radiation would be helpful or not. And so there are multiple nuances which we need to learn, and but it is still a big enough field for us to get educated and try to spread the awareness about sarcomas. I work at the Apollo Proton Cancer Center, and for all the audience, I would be, obviously it is for general public, so I will try my best to make sure that I don't use too much technical words. And in the next few slides, I would like to tell you what is proton therapy. Before coming to proton therapy, I think Dr. Vivek very nicely mentioned about what are sarcomas and how they are treated, and surgery forms the crux of the treatment for sarcomas. Indeed, it is true, but radiation therapy and other therapies also do play a major role in caring for these patients. And radiation therapy is one of the oldest anti-cancer therapies known. It's been known since more than 100 years. And how does radiation therapy work? Radiation therapy basically induces DNA damage, which is either single-stranded or double-stranded. And we all know that DNA, which is essentially the life of any cell, is if you damage that life of the cell, the DNA damage leads to effectively killing or sterilizing the cancer cells. And radiation has direct or indirect effects on DNA. So the direct effect is when it by itself can cause DNA break, or it would react with other chemicals such as water, which is the most commonly available chemical in the body, and it forms certain reactive species or unstable species, which leads to a chemical lysis of the DNA. So these are the direct and indirect effects of radiation therapy. And when we speak conventional radiation or X-ray therapy, the indirect effect predominates, which is reactive species formation because of certain chemistry, and then that leading to DNA damage is the predominant effect, and a small direct action is there. But if you see a radiation for bone tumors, and that has also been practiced since several decades, but there are several bone tumors. There are tumors such as something called lymphoma or multiple myeloma, or even plasmacytomas, where you need a lesser dose of radiation, but you have certain tumors which fall into the category of sarcomas, where they need a very high doses of radiation to achieve a good control over the disease. And traditionally, these were put in a basket and they were labeled as radio resistant. And indeed, they were not radio resistant, but they needed much more doses of radiation to get controlled compared to the more radiosensitive tumors. And typically, we use surgery is a predominant treatment in most of these bone tumors. So we combine radiation with surgery. So sometimes we give radiation before surgery, we call as preoperative treatment. Sometimes we give it in a definitive setting where the surgeon says that it is not possible to resect a particular tumor without causing a significant amount of physical handicap or structural deformities. And in that situation, we jump in and we probably sometimes offer definitive radiation therapy in sarcomas. There are also situations when the surgeon operates and we feel that there could be disease still left over by the surgeon, or it could be even microscopic. Despite the surgeon removing whatever is visible, there could still be microscopic tumor within the area where the tumor was resected. And that would need certain amount of further treatment, adjuvant treatment, to ensure that there is a good control over the disease. And sometimes we use teletherapy. The most common type of radiation is teletherapy, which is external beam radiation therapy, which is given from outside the body. Sometimes intraoperative treatment is also given from outside, or in fact, we put the radioactive needles. We put needles into the tumor and then send in some radiation into the tumor. So that is also called brachytherapy. So these are some of the commonly used settings of radiation. Sometimes the surgeon takes out the bone and it is irradiated outside in a controlled environment, of course, and we can give very high dose of radiation. Once the tissue is irradiated, the tissue is brought back and it is implanted into the body. So that is called extracorporeal radiation therapy. And sometimes we do give radiation in situations where we are not able to cure the patient, but the patient has a lot of symptoms such as pain or bleeding. We intervene, and radiation is known to reduce pain and bleeding in certain situations. And that is not to cure the disease or control the disease, but essentially to palliate the symptoms, and that is called a palliative radiation therapy. So overall, as I mentioned, it is being less common. There are not many randomized trials. Randomized trial is one of the instruments through which we generate evidence, good quality evidence. Therein we subject patients to a randomized trial where about half the patients would go in for, say, experimental treatment, half the patients would receive the standard treatment, and based on which arm, which group of patients have better outcome, that is labeled as the new standard of care. And because these randomized trials are difficult to do in rare tumors such as sarcomas, we have to rely on prospective and good retrospective studies. And hence there's a lot of variation in when you give dose and technique and settings. And I'm sure you will probably also see some difference in how we treat sarcomas in different regions, different geographies, and in using different philosophies of treatment. So characteristics of X-rays, because the X-ray deposits a lot of energy in the beginning of its beam path. When it enters the body, it deposits most of the energy just below the skin. And as the X-ray travels across the body, the dose is significantly attenuated or comes down, and that is the reason why we need to make sure that when we give radiation, we don't include the critical organs, because the DNA damage can not just happen in the tumor, but it also can happen in the critical structures, and we wouldn't want that to happen. And fortunately, God is, probably, whoever has created us has made critical organs very unique in the way that there is a lot of capability of repair. So there, even though a little bit of radiation does go to the critical organs, that gets repaired, but the tumor is destroyed. So that is what we base our entire treatment on. And there have been significant advances in radiation oncology, as Dr. Vivek mentioned. So 20 years ago, when I joined, about 20 years ago, when I joined my post-graduation, Tata Memorial, 3D CRT was a standard where it's called 3D conformal radiation therapy, where we give to the tumor with 3 or 4 fields of treatment, make sure that it doesn't go through a critical structure, and make sure that the high dose region is is received by the tumor, and the low doses are spread across the body, across the tumor into the normal body. With IMRT came a major advances where you can see that the high dose region, which is what we want the tumor to receive, is received only by the tumor, but the rest of the structures are where the dose is minimized compared to 3D conformal radiation therapy. This is called an intensity modulated radiation therapy. This is a slight modification of intensity modulated radiation, which is called a volumetric modulated arc therapy, which is very similar to IMRT. It takes less time to irradiate large structures, and you get a little bit of conformity. You see that the high dose region is restricted only to the tumor, which is marked in the red. The green one, which is slightly intermediate doses, is still going around the tumor, but the normal structures is actually receiving very, very low doses. Most of the normal structures are receiving low doses. So despite the major advances in radiation oncology, you still end up giving a lot of those to the critical structures. Most of the situations, we ensure that the normal structures do not they're not damaged beyond repair. We ensure so certain structures such as spinal cord, brainstem are given extreme priority to make sure that they are not they're not irradiated to high doses, and make sure that we don't produce significant toxicities in a patient. Then comes proton therapy. It's been there since a few decades now, but there have been a lot of advances in proton therapy as well. But what is unique about proton therapy is, I've already spoken about conventional X-rays, where you see that most of the dose is deposited just below the skin. But the proton has a unique physical property wherein it enters the body, but it does not deposit its maximum energy till it travels a particular depth. And that depth is called a range. So for example, a particular energy proton, most of times we use slightly higher energy protons, but whenever you use these protons, the dose deposited in the beginning of the beam path is very little, but it deposits majority of the energy in a few millimeter radius. And we call this phenomena as Bragg peak. Of course, tumors are not in millimeters, so we do a particular modification to make sure that the Bragg peaks fall inside the tumor so that the tumor is irradiated. But the characteristic of proton, which is there is no exit beam. So you see that there is absolute fall in the dose beyond the tumor, and there is no dose beyond the particular tumor. So you can see that the exit dose is significantly reduced. So for example, this was one of the first sacral chordomas which I've treated at the Proton Center 2 years ago. You see that this was very close to the sacrum, very close to the rectum. And we did a plan on VMAT, and we have a tomotherapy system, which is also basically a different form of IMRT. And you see that there is a significant low to intermediate doses to the bladder, to the urinary bladder, to the rectum, to the bones, the pelvic bones, and the marrow which is contained within the pelvic bones, and other structures such as bowel and other pelvic organs. But you see, if you see a proton therapy plan, since we used a few beams, we made sure, as I mentioned, there is no exit dose. And we make sure that the beam ends here, and we've ensured that the bladder receives almost no doses to the urinary bladder or to the pelvic marrow, or superiorly to the bowel. So you can see that the rectum is spared of most of the radiation. Bladder is spared. So this is the advantage of using proton therapy in terms of physical ability to spare normal structures and reduce the probability of collateral damage when we use radiation therapy. Apart from the physical aspects of proton therapy, physical advantages of proton therapy, there could be some biological advantages of proton therapy, which we are still trying to understand. There is certainly at least a theoretical advantage that along the Bragg peak, proton could be more effective than X-rays, could be about from 10 to nearly 50–60% more effective than on an equally effective X-ray radiation. So if you give a dose of say 70 gray of X-ray and 70 gray of proton, they are not equal, but the 70 gray of proton is actually equivalent to a little bit more, about 10% more of the effectiveness. So that is because there are multiple reasons. That is because the damage is very complex. The DNA damage is more complex, so it cannot be repaired easily, and there are other genetic and immunological factors. I will not go into detail, but there is some theoretical biological advantage as well with proton therapy. And with this, before the COVID hit us, we have treated a significant proportion of patients at Proton Center, and they were all there was a significant chunk of tumors were of musculoskeletal tumors. And this was the distribution. We treated about 42 till about March of this year. So thank you so much for giving me this opportunity. This is our Proton Center at Chennai. And this is one of the Proton rooms which we have commissioned about 2 years ago. Thank you so much.